started. Joe, do you want to go ahead and give me 1 second to then share my screen. All right, welcome everybody to it's February, the February online JVS Journal Club. We are excited to have everyone here. Just so everyone knows, this is being recorded for those that aren't able to make it today. We have 2 really exciting papers coming out of the February JVS. The first is a multi-center experience with an off-the-shelf single retrograde thoracic branched endoprosthesis for acute aortic pathology. And the second is graduating vascular surgery trainee proficiency in endovascular and open peripheral revascularization procedures. Our 2 host institutions tonight are Mayo Clinic, Dr. Sen, who is an assistant professor of surgery, and vascular fellow there, Dr. Alice Pizzanini. From the University of Iowa, Dr. Obaisi, and the 3rd-year vascular resident, Dr. Chahor, will be presenting. We also really appreciate that the authors from both papers can make it. It tends to be a great time to interact and to really get information. So Dr. Steve Maximus, who is the senior author on the TBE paper, along with Dr. Catherine DeLosa, who is a 5th-year vascular trainee who's graduating this year. And then from there are several different places. Everybody here is from, nobody's from the same place, it seems like. Everybody is from multiple places. So from the University of Virginia, we have Dr. Aaron Buchanan, who is a 2nd-year vascular fellow, but Dr. Libby Weaver, who is now at the University of Utah, assistant professor of surgery, and Dr. Bridget Smith, who's now at the University of Wisconsin, who's an associate professor of surgery, who's also going to be joining us to help with their article. And then we have our 2 moderators, Dr. Sarah Deary, who is at Maine Health. She's the first physician in Maine to use the TBE. And then Dr. Kelly Kemp, who is an associate professor of surgery and a program director at the University of Oklahoma. We ask that you please stay muted. You can put your questions or comments in the chat, and the moderator may call on you to speak. We have the March version of the JVS Online Journal Club, which will be Wednesday, March 12th at 6 p.m., hosted by Houston Methodist and NYU. All of the current dates for 2025 are posted on vascular.org. And you'll also see more of the Young Surgeon section participating in the JVS Online Journal Club. So we're excited to have them hosting tonight, but also you'll see more of their participation in this as we go forward. So I will stop. And Dr. Sen, do you want to start us off?
Thank you for the invite and thanks for allowing us to present today. Let me make sure I share things right. And can everybody see my slides and hear me?
We can.
Wonderful. So I'll get started with just an introduction of our first paper, the multi-center experience of the TBE. And if I'm looking away, it's because I have 2 screens here. So essentially, we all kind of know that the thoracic branch endoprosthesis is another of the Go devices. And essentially, its construct is to allow continued supply to the left subclavian. It has an aortic component, an extender, and a side branch component. It's essentially another PTFE stent with nitinol and gold. The components themselves have specific design sizes which kind of allow treatment of these various pathologies. The aortic component is as demonstrated here. It has a proximal segment with a branch device that fits into the 15mm length with these specific markers, which you'll see in a little bit in a case demonstration, as well as this side branch component, which again, depending on the size that the patient needs, has various configurations. The proximal aortic landing zone requirements are that there is an adequate iliac or femoral access, and I'm sure in the discussion there will be some talk about that because this can sometimes be restrictive. for a reader aortic diameter from 16 to 42 millimeter that can be treated. The proximal landing zone should not be aneurysmal, heavily dissected or calcified. And however, there is the possibility to treat patients who've had a previous graft. The primary entry tear for dissections patients should be distal to the left subclavian. And again, this I think, will be something that, will be up for discussion. I'm very glad that the authors are here, and I really have a lot of questions for them. So for indications for use, again, for the proximal landing zone, at least 2 to 4 centimeter, depending on the aortic component selection. And for the proximal covered length, at least 15 to 36 millimeter. There are all these charts, which are obviously familiar to all of us. And again, kind of demonstrates that the left subclavian inner diameter needs to be anywhere between 6 and 18 millimeter, and a length of 2.5 to 3 centimeter, again, depending on what device is chosen. The distal landing zone needs to be per IFU within 2 centimeter of the celiac artery, with an aortic inner diameter of 16 to 42 at this area as well, with the same kind of non-calcified, non-thrombosed requirements. The extender piece is a much shorter cuff, and again, comes in different sizes. Procedural steps very quickly before Alice takes over for the presentation. Usually under general anesthesia, no spinal drain, no carbon dioxide flushing, IVUS as needed, with bilateral femoral and either radial or brachial access. The second step is essentially loading the device on and then introducing it through a dry seal. The crossbody wire is obviously snared at an appropriate location depending on the patient's anatomy. Following that, the device is taken up into the arch. We avoided wire wrap as demonstrated here. And the side branch component is delivered using a push-pull maneuver. Following deployment of all the components, the side branch is ballooned, and that's essentially a quick and relatively painless procedure in comparison to what we used to need to do. And with that, I'll hand over to Alice.
Yeah, I'm gonna share my screen. Can everybody hear me and see my screen?
We can. Perfect.
Okay, perfect. Thank you. So thanks for having me here to present this paper. So just as a quick introduction to add to what Dr. Sen said, so the acute aortic condition that requires urgent intervention with the coverage of the left subclavian artery increase the risk of stroke, arm ischemia, spinal cord ischemia. And we know that open surgical repair are challenging because of high mortality and morbidity and prolonged ICU and hospital stay. With the evolution of TEVAR, we have seen different options to obviate of the risk of stroke, arm ischemia, and spinal cord ischemia with the branching, parallel grafting, and in situ fenestrations. So the study objective of the multi-center study that we're presenting here is to assess technical success and early outcomes of the GOR-TBE device in urgent and emergent aortic repair. The primary endpoints that we're look at were technical success, and the technical success was defined as a successful delivery of the device with the side branch patency and exclusion of the pathology. 30-day all-cause mortality, aortic mortality, and major adverse event that included stroke, paraplegia, dialysis, MI, bowel ischemia, and prolonged intubation. So this study is a multi-center retrospective studies that included 7 different centers, collected patient between March 2017 and March 2024. The total patient were 107. The majority of the patient presented with complicated aortic dissection of 65%, followed by 20% of symptomatic aneurysm and pseudoaneurysm, and 15% of blunt aortic injury. Elective repair were excluded. Looking at some demographic of the population, the majority were male with 69%. The mean age was 60 years old, plus minus the 15 years. Looking at the different races, the majority of the patient with a 38% were white. as comorbidity were concerned, a high percentage at hypertension with 85%, 51% were tobacco users. CAD was in 22% of the patients, hyperlipidemia, diabetes, and CKD as 30%. As far as the pathology history, pathology of the patients, 3 patients had a family history of aortic disease, 2 patients had connective tissue disorders, and 17, which also was equivalent to 17%, had a prior open aortic repair, and only 2 had a prior endovascular repair. As far as the prior open aortic repair, the 17 patient that I just mentioned, 15 had a ascending aortic repair. Just getting into details of the procedure, they were all done under general anesthesia. 26% had a lumbar drain placed intra-op. As far as access was concerned, 65% had a percutaneous femoral and radial, followed by percutaneous femoral and brachial, and 11% with femoral and open axillary. The choice of using proximal extension and other devices distally was up to the surgeon, and the oversizing of the graft was usually 10 to 20%. As far as devices sheet, the majority used were 22 French, and for landing zone, 91% with 89% were in zone 2, followed by zone 0 and zone 1. These are some data as far as time of procedure, with 140 minutes total procedure time, and the longest was in the aneurysm group. The quickest was in the blunt thoracic aortic injury. Some other procedure detail, the majority of the patients had a type 1 arch anatomy, 59% of them. The type 1 required in 18% of them proximal cuff, and type 2, 13%, and type 3, 25%. The graft had a slippage in 4 patients, and 12 patients required great vessel debranching. As far as the length of the coverage of the aorta, the overall was 21%. It was 21 in the dissection, specifically 23 in the aneurysmal disease, and 17 in the blunt thoracic aortic injury. For distal landing, the majority were landed in zone 4 and 5, both for the dissection group and the aneurysm group. 47% of the patient required additional uncover stents. 99% of the patient had technical success. One of them had a dissection with an aneurysmal degeneration that required stage repair, and 2% of the patient had a 30-day mortality. For the major adverse event, they were noticed in 18%. The highest percentage was for stroke, 6%, followed by paraplegia, retrograde aortic dissection in 5 patients. They were all in zone 2, and AKI requiring dialysis only in 1 patient, and 2 patients had a pneumonia. These are just some major adverse event divided by pathology, and we can notice that the blunt thoracic aortic injury had none. The aneurysm, so the dissection group is the one with the highest number of all adverse event. Gender, race, and ethnicity were not influential in the death rate and the major event. As far as disposition, the majority of the patient were discharged home, 72%, followed by SNF, 26%, to had a mortality. The mean follow-up of this patient was 55 days, and 94% of them had some follow-up with imaging. To go back to some important complications, spinal cord ischemia were noticed in 6 patients, and it was noticed both in patients with and without lumbar drain. This patient had landing zone in zone 4 in 2 of them, and 4 of them were in zone 5. The coverage length average was 20% with patients that had spinal cord ischemia. Retrograde dissection was happened in 5 patients. They were all in zone 2. 4 of them were managed with the medical management, and 1 of them required an additional T-bar. endoleaks. There were 5 type 1A endoleaks, 2 type 3 endoleak with graft separation, and 1 retrograde branch occlusion. 11 patients require intervention. So just as an overall quick discussion, so the TVAR from all these data appear to, with the GORE TB, appear to be a technique that has high technical success in 99% and a low 30-day mortality, only 2%, especially in the blunt thoracic aortic injury and aneurysm. The dissection group is the group that presented with a higher risk of stroke and spinal cord ischemia, and they're patients that require careful follow-up and monitoring. And there might be some benefit from prophylactic lumbar drain to prevent paraplegia. The limitation was a short follow-up of the patients, plus being a retrospective study. So in conclusion, this study confirmed that the TVAR with the GORE TB is an effective technique for acute aortic pathology. It offers a safe alternative to open surgery and hybrid approaches, in particular for zone 2 pathology. While the complication was moderate, only 18% of the dissection continued to be the highest risk category, and some long-term studies are needed to evaluate how durable these repairs are, particularly regarding the retrograde dissection. Thank you.
All right. That was a great discussion and overview of those papers. So thank you all for that. There's already a few things coming up in the chat, so I'll start with some of these comments. Someone was commenting on the spinal cord ischemia, and that's something that I also thought was pretty interesting. I was surprised to see that the average coverage length, even for patients with spinal cord ischemia, was only 20 centimeters, because that's generally something that I would consider a very short piece, particularly when part of that is proximal to the left subclavian. So I was kind of surprised by that. I'm mostly just wondering what the management of the spinal drains was. Did you seem to see that there were certain centers that would always place a spinal drain and others would do it selectively? What was the practice pattern for how only 25% ended up with a spinal drain to start?
So I can answer.
Yeah, you can do that.
Sorry, so I can answer for 2 of the centers at least, because I have experience at both UT and UC Davis. At both of our institutions, we really placed them selectively. Some of these patients obviously were very acute where we couldn't do EEG monitoring, but for most of our cases at both institutions, we do neural monitoring and place them selectively. Found that, the spinal drains themselves have about a 10% complication rate. So we basically put in rescue drains when the patients have symptoms or if we see any changes on the neural monitoring. To answer the other questions that I saw, oversizing most of these patients were acute dissections, so they were all within 14 days, so not a lot of subacutes, but either way, we oversized more about 10%, but again, it was retrospective. And then deciding on whom to go down to zone 5, again, that was surgeon preference. There wasn't a protocol or anything that we followed. I know our practice at Davis and at UT was that, we would basically try to have the minimum coverage length as we could for dissection. But again, the whole goal, mostly in complicated dissection, usually these are patients with malperfusion, at least in those 2 groups. So our goal was to restore visceral flow. So usually our protocol is we'll put the proximal TB in, IVUS again, see if the true lumen has opened up. If it hasn't, then we'd go down to the celiac with a stent graft, a C-tag. And then if there still was perfusion deficits, then we usually would finish it off with a petticoat. In terms of the coverage linked with the pathology, I think, the aneurysm patients, yeah, it is very interesting. I can't give you a good reason. I think the dissection patients, again, these were complicated dissection, and we know that another major risk factor for spinal cord ischemia is hypotension. So I think that could probably have played a part in it, but again, it's hard to infer that from a retrospective style. And then in terms of how many patients were excluded, again, we didn't look at that. We only looked at patients that underwent TBE at the institutions, and then we sorted them out for acute. In terms of short distances, that's something that actually Sukohan and I have been working on for patients who are done off IFU. So we actually, I think we submitted that to SVS, and patients who have less than 50 millimeters. And really, there hasn't been an outcome. Sorry, there hasn't been any increased complications with type 1A endoleaks or anything like that. So you can use it in shorter distances, and we are publishing that.
Yeah, I think with the dissection, I mean, I've seen that when you put in the stent and the false lumen thrombosis and all the lumbars are coming off this false lumen and the intercostals and lumbars, that they end up getting a lot more taken out than just the coverage length of the device. And so that's probably at least somewhat related. Certainly seen that happen. That's a great question from Dr. Smith. Were any of the spinal cord ischemia patients trauma patients?
No, the trauma, the blunt traumatic aortic injuries had no complications. They had zero complications. Again, those were pretty, I want to say straightforward. They were all grade threes and above. But they were one piece, shorter operations, obviously not as complicated as a dissection. In terms of the retrograde dissections, I agree that is catastrophic. The interesting thing about them, they all occurred after 30 days. I know two of them were ours. And one I remember very clearly. It was actually a patient, methamphetamine user. He actually, his presenting symptom was paraplegia. So we put a lumbar drain in him, did the TBE, sent him down to the celiac petticoat after that. And he actually regained full function after we treated him, did fine. And then 2 to 3 months later, came back again, used methamphetamine. Pressures were in the 200, and he retrograde dissected. And similarly on another patient, it was patients who were heavy methamphetamine users. So I know at least 2 out of the 5 were ours who retrograde dissected after 30 days. And I think it's more a failure of, medical management on hypertension and continued drug use than it was the device. But it's certainly something to look at in terms of predictive factors.
Another question for Dr. Maximus and maybe some of the other people on the call. Just in general, I've seen at our institution, our typical pattern for treating the blunt thoracic aortic injury, they're almost always in the same place, and they're always kind of right at the left subclavian, and you can almost always land the device right at the common carotid. And we would generally just put in a very short piece, cover the left subclavian, no big deal. And I've definitely seen that we've started to transition towards using TBEs. And I was wondering if that's what other people are doing too. And if you think that there's necessarily a benefit for doing the TBE as opposed to just covering, since they generally do quite well.
We actually looked at that as well in our own data. We compared our outcomes between patients with a blunt injury that were repaired with a TBE versus those that had coverage of the left subclavian. And there were almost 30% of patients that had coverage of the left subclavian that ended up having a complication or a reintervention for ischemic symptoms or stroke. So we generally prefer to do that as opposed to covering the left subclavian, especially considering we have ready access to the grafts.
Yeah, I'll tell you, if you can save it, I think it's worthwhile still. Certainly, covering it, you can get away with that. But I've had a number of patients who come back later and they were in that cohort who just say, man, my left arm just, it gets tired out and I have claudication. And, a lot of these trauma patients don't follow up, as we all know. But the ones who do, it's not a small percentage that we found that we re-intervened either with carotid subclavian bypass or, did a snorkel, basically snuck a stent through and treated them that way. So it wasn't totally insignificant. And I think, obviously it's a more expensive device and it takes a little bit more time, but I think if you can save it, I don't think there's any good reason not to. If their anatomy fits.
So Dr. Maximus, a little bit more generally, just in regards to the study design, I was wondering if you could talk a little bit more just about how to get one of these multi-center registries going. This is the Young Surgeon Society section, and you're sort of youngish. So I mean, it's pretty impressive that you got this coordinated. So I think talking a little bit more about that would be helpful for many of us.
Sure. It was actually just talking to Suku. So, the Gore guys were talking about who's done a lot of TBEs, and I talked to Suku, he's a good friend of mine, and I was like, hey, how many have you done? And he's like, I've done this many. And I was like, how many for acute? And he said this many. So we decided to combine our data. And then I talked to Gustavo about it, and he was a mentor. He's a mentor of mine, obviously. And this was before I joined his group. And I said, "Hey, how many of you guys done?" And he said, oh, I've done this many. So once I had talked to Gustavo and Suku, and Gustavo suggested, he's like, oh, why don't you talk to other people and reach out? And it was really just reaching out to people and seeing if they were interested. I found out who the high volume users were, and everybody was really, really interested and open and being part of it and pretty excited. And, Kat did a great job. I have to give her a lot of the credit. She, went out and talked to their research people, and she did all the heavy lifting. I just initially got people's interest. And from there, she kind of took off with it. But yeah, I was just basically talking, saying how many they did, and I was surprised at how many people wanted to be a part of it.
Awesome. Well, great work.
Thank you.
Thank you. I think that's a great kind of segue into our next paper, but this idea that we can all come together, and our Dr. Delosa is one of the residents here at UC Davis, and it does take some coordination, getting data use agreements and getting everyone kind of organized under all of that. So it's something that for anyone who has questions, I'm sure she'll be able to share some of the logistics if you wanted to reach out with her, if you haven't done it before too. So with that, we're going to switch to an educational session. Dr. Obagesi, do you want to start?
Of course, thank you. Thank you to JVS and thank you to everyone for allowing us to host today. As a relatively new graduate, I found this article really interesting, learned a lot from it. Essentially, it was an educational article looking at the preparedness of our trainees, fellows, and residents, and open and endovascular interventions at the time of graduation. Again, like I said, as a new graduate, I kind of looked at this and kind of looked at it from when I was a PGY1 to when I graduated as a PGY5, and just looked at the trend. So with that being said, I will allow our resident, Dr. Shiro, our PGY3 resident, to go over the article in great detail.
Thank you for having us and then giving us the opportunity to present this very interesting paper. Just want to confirm that everyone can see my slides and can hear me.
Absolutely, it looks great.
Perfect. So I'll be presenting the paper Graduating Vascular Surgery Trainee Proficiency in Endovascular and Open Periphery Vascularization Procedures. This is a paper it was a collaboration between University of Virginia, University of Utah, and University of Wisconsin. So as an introduction, there has been a change in the case volume of vascular surgery trainees over time. Trainees are doing more endovascular cases and are actually also doing more open cases. And it's unknown what the impact on competence is. Are the cases less complex? Are trainees being less autonomous? So the aim of this study was to investigate the autonomy and proficiency of trainees and compare those aspects when it comes to endovascular and open procedures, as well as predict the probability of achieving proficiency upon graduation. For the methods, this was a cohort study. Data was from the simple application, which is a performance and autonomy assessment tool. It includes of trainee, and it includes both assessments from faculty and self-assessments. For the data analysis, the authors used Fisher's exact test to compare across categories, and they used logistic regression to estimate association between procedure types and outcomes. So for the results, the paper included the data on 69 different trainees. Most of the trainees were senior level trainees, PGY 4, 5, 6, or 7. And there were 17 programs that were included in the study. Overall, the paper included 329 assessments done by faculty and 377 assessments done by trainees. When it comes to the complexity of the cases, looking at the endovascular complexity, almost 20% of cases were in the hardest one third of complexity, and as evaluated or as judged by the faculty and 17.6% by trainees. And interestingly, 40% of the cases, of the open cases, were considered as hardest one-third, as opposed to 26 when it comes to the trainees. This table, this graph shows how the trend of autonomy difference between the different years of training. So as expected, when as a PGY1 you have more show and tell, more active help, more passive help, and as you advance in your training, you are getting less, you are getting more autonomy. You are doing cases with supervision only. Uh, One interesting finding from this graph is that trainees, almost when it comes to autonomy, half of the trainees, or the percentage of trainees who thought that they were doing cases with supervision only, was half of what faculty thought. This is similar, but when it comes to performance, uh, again, as you advance in your training, you are being better when it comes to performance, and both the trainee and the faculty are thinking that you are practice ready or even doing exceptional performance. It's interesting here. There's like a small, tiny bit of trainees who thought they did exceptional performance. When it comes to factors that would suggest, or factors that are associated with being autonomous, uh, again, as expected, as you advance with your training year, you're more autonomous. As you advance in the week of training, you are also more autonomous. Uh, when it comes to case complexity, it's the other way around. So the hardest cases have less autonomy. Similar results were seen when it comes to competence. I think one notable finding was that per trainees, the open cases were the trainees felt that they are less competent in open cases as compared to what the faculty thought. Finally, when it comes to the results, this is a graph showing the predicted probability of achieving autonomy and competence upon graduation per faculty and uh, per faculty for endo and for open cases. So for the easiest cases, whether it's open or endo, you have pretty good predicted probability of above 90% of being competent and autonomous. Similarly, for the average, when it comes to the hardest one-third, uh, the faculty thought that trainees are autonomous. However, when it comes to competence, there's a bit of a difference there. We're talking somewhere in the 70%, and this is discussed later by the authors, who bring very important points of this in their discussion. So, first takeaway message was trainees are well prepared to treat peripheral arterial disease upon graduation. There was no difference in competence and autonomy between open and endo cases after adjusting for case complexity. However, as shown previously, trainees felt more confident about their endovascular skills. In high complexity cases, graduates would benefit from the assistance of senior partners. There is some discordance in autonomy perceptions between staff and residents. Residents thought that they are getting less autonomy. And the authors suggest strategies to align perceptions between the residents and the faculty. The three important points that I found were: set the expectations before cases, increase the frequency of feedback, and move from the concept of autonomy to the concept of entrustment. Finally, the authors mentioned a couple limitations, including that this was from limited number of programs, limited number of cases, and limited number of evaluations, and this paper only included peripheral interventions. Thank you.
a great paper and a great presentation. Appreciate it very much. So we're very grateful to have so many of the authors here today. So one of the things that I thought we should talk about initially is really that difference, as Dr. Maximus brought up, between the trainee and faculty assessment of autonomy. Were you surprised with this particular result?
Hi. I'm gonna let Dr. Buchanan answer because she did an excellent job with this paper, and I will be happy to chime in with any additional thoughts, but I'm gonna let her lead the way.
Okay, Dr. Buchanan, it's all you.
Great. I think having been a trainee now in both the general surgery residency and vascular fellowship, it's not terribly surprising to me that there's a difference. I think that the way that trainees feel when they're in the operating room in terms of how much autonomy they're getting and how much of the case they're doing versus probably how the faculty are feeling about how much they're allowing, stepping back and allowing the resident to take, or the fellow to take control or direct the care of the patient is probably very different and something I think about a lot as I approach graduation. I also think that the understanding of how much you are doing in the operating room changes as you proceed through training. So thinking about all the next steps and what you're going to do next in the operation and planning what happens A, B, and C in terms of if something's not going quite right is probably something more that senior level trainees are thinking, and probably what the faculty are thinking about the whole time that they're trying to take the trainee through the case. And so I think that probably also plays a role, which is not something that we can really flesh out with the data that we have here.
Right. There's a lot of internal communication, right? That doesn't actually happen on the outside. So I think that's really fascinating. And I'm wondering, just if I may, do you see yourself shifting your perception as you are becoming a faculty member and teaching younger generation?
I definitely can see that the way that I think about the operation is different. Trying to take residents through the cases that was recently taking me through, realizing what decisions they were making for me as we went that I was unaware of. And I think that is a good point too. So I think that there's different types of autonomy also. Like when I'm taking a senior resident through a case now, and my faculty is trying to stand away and watch me do that, those are all different levels of autonomy and competence, I think, from all the players that are in the room at the time.
Well said. All right. So was there a difference between progression of improvement over time for different types of cases?
This paper was only for peripheral inguinal cases, but that is a great point. We are interested in looking at that as well. The main question at the presentation for the last BAM meeting was, what do we see in aortic cases, which of course is everyone's maybe big wonder of how are we doing in terms of trainees in that perspective. So we will hopefully look at those things looking forward, but we're not quite there yet. Maybe Dr. Weaver or Dr. Smith have some comments on that.
We do have an abstract under review, I guess, of the aortic work, and I really hope it gets to get presented soon because it's somewhat shocking. I was pretty pleased, I guess, overall with the prediction of how prepared our trainees would be with both types of peripheral work. And I do want to emphasize that our predictive model isn't saying that 89% or whatever of graduates will be ready to do this case at graduation. It's saying that 89% of the time, or whatever our final number was for open versus endo, in an average complexity case, that person will be able to do that independently, which I think is what most of us, I'm a fairly new attending myself. I'm in my third year. I think that's what most of us feel. Like most of the time we're okay, but every now and then we need to call in a partner to say, I'm tunneling it this way. Is this dumb? Or can you look at this angio? This is what I'm thinking. that happens occasionally. And I think, as Ted mentioned in the comments, this just really highlights that being an independent practice doesn't mean you should be solo. And I think that we as faculty need to support our more junior faculty with mentorship as they enter practice.
So just as an aside, Dr. Weaver, I totally agree. And we all need additional set of hands throughout our entire career, I would say. Okay, and it's completely all right to ask for these things. From Dr. Forbes, Dr. Forbes wants to know more about the differences between trainees' evaluation of autonomy versus faculty, and was wondering specifically if there's any relationship to case volume or regional or program specific differences. And I know there was limitations here, but I'm wondering if y'all can comment on that.
I don't know that I specifically know the answer to that, actually.
We did take programmatic effects into consideration because we do see trends in how different programs tend to rate trainees. And so we clustered by program to take that into effect. Complexity was taken into effect, different variables like that. Case volume is the one thing that we do not have a link to. Obviously, we can look at the number of cases that were assessed, but that's not the same as the number of cases that that trainee is necessarily doing. So that I think that's an excellent next direction, because a lot of our education research does revolve around case volume, which is kind of the best thing we have, other than some of this multi-institutional data, to understand case competency. But we all know that case volume is not the same. It's not a direct marker of proficiency. There are so many variables in terms of the complexity of the case, how much autonomy you receive during that case, what you're even doing the case for, a FEMPOP bypass or trauma or CLTI or an aneurysm. You know, these are all different types of cases. And so it's hard to really discern proficiency from case volume. And I think that a great next step for some of this education research is to figure out a way to understand how good of a surrogate case volume is for proficiency, and to link some of these assessments with case volume.
Pretty amazing. Okay, so Dr. Peter Nelson wants to turn the question upside down a little bit. Do trainees ever express that they are getting too much autonomy and want more oversight or participation of the faculty? And I know it's not really what you discussed and found in your paper, but it would be great for some additional insight on this question.
Yeah, I think that unfortunately the way that our data is gathered, it doesn't necessarily tell us that information. You might be able to infer it somewhat from looking at the proportion of trainees that might be saying that they feel like they're being autonomous or feel completely competent. And as that proportion grows, that would indicate that they don't feel like they need the faculty as much. So if you have senior level trainees rating themselves at not necessarily practice ready practice and not feeling really competent, it might reflect that they felt that they needed their faculty more during that procedure. But that would be kind of an inference from this data, not necessarily direct.
Yeah, we have done some other studies with this data looking at all cases and focusing more on that autonomy piece. I don't know. I think it was previously published in JVS, or it's going to be. I don't know. It's online. But we did one that we focused a little bit more on gender differences, because that's where we saw some major differences. And it's pretty consistent that trainees seem to underestimate both their competency and autonomy. Trainees of all genders seem to underestimate as compared to their faculty assessors. Women underestimate to a significantly greater degree than men do. Even though there is no difference in how men and women are assessed across our total data bank from Simple, which is like thousands of assessments. So I think this is, somebody put something about EPAs in the chat, but I think this is where, as a specialty, we're starting to shift our thinking from autonomy to entrustment, which is a little bit different. I think autonomy suggests that this is like a a pizza that has X amount of slices, and the faculty member gets this many and the trainee gets this many. Whereas entrustment's more about like a shared sort of relationship with the trainee and faculty. And it also, you know, puts it a little bit on the trainee to show preparation and to show initiative during the case and so on and so forth. So I think this is where potentially shifting our assessments to EPAs is going to maybe help align how faculty and trainees see this independence during case. These EPAs also have really specific behavioral anchors for any of you that are part of the pilot that have used them, which may also help better align trainees and faculty in terms of how much entrustment there is during a case. This is actually, I'm in graduate school right now, and this is my thesis project, so maybe we will talk about this sometime next year.
All right. So it says it seems like there was a difference between the integrated PTY 6-7 and fellows in terms of autonomy and performance, whether it's on the training level or the faculty level. Wondering what are the contributing factors?
I guess I think about this to a degree as a general surgery resident coming into vascular fellowship. There were a lot of things, especially endovascular procedures, that I felt very uncomfortable with. And so I think that there are some components of your previous training years as we came into the senior level trainee level. But I think the important part about the overall data set was that by completion of training, all of the competency and the autonomy practice across both, whether you were an integrated resident graduating or a vascular fellow graduating, were equal in terms of their comfort and knowledge base, or comfort and competency with both open and endo procedures.
Yeah, in this study, I put in the chat, sorry, just to remind everybody that we lumped together the integrated 4 and the fellow that was a first-year fellow, the integrated 5 and the second-year fellow. So those groups were lumped together in those senior years. We've done other investigations of this data set where we've looked at differences between fellows and residents, senior fellows and senior residents in open and in endovascular procedures. And we have seen that there's less autonomy and maybe also lower performance, if I remember right, for the fellows in their PG in their first year as a fellow, and they quickly catch up. So the long story short is that everybody finishes at the same level.
Dr. DeLosa had an interesting question. Did you find that programs with both integrated residents and fellowships, or programs with additional super fellows in addition to their trainees, did it change results? You may not have had the numbers to look at this, but I think it's a question that a lot of us as educators really are interested in, as far as fellows and integrated residents working together.
Unfortunately, I don't think we quite had the breakdown for that.
We did not, but we don't have the breakdown for that, but we have done another study. I have done very few senior author studies at this point in my career, but one of the only other ones I've done did look at general surgery vascular proficiency, general surgery resident vascular case proficiency in settings of an integrated residency, a fellowship only, or no training programs. And interestingly, when general surgery residents are around integrated residents, they tend to graduate with higher levels of proficiency and autonomy. And the opposite happens with trainees that are not around any vascular fellows or residents. And you know, we don't know the cause of that, but my theory is that when you develop these sort of shared educational relationships over time, you've got integrated residents going through 5 years with general surgery residents, you sort of collaborate as learners as well, and you're comparing yourself to somebody that's your peer and saying, well, this person is at this level, I need to be at this level. And I think it has almost the opposite effect of what most of us expect might happen.
Fantastic. So one of the other questions that really I had burning was, what other papers you have cooking. And so you already enticed us with the aortic work. So do you have anything else in the works?
With simple data, we do have the aorta project. We also have this is not simple data, but we also have the analysis for case volume with respect to gender, race, and ethnicity in our vascular trainees that I hope will be presented sometime soon. And then we have some other EPA related projects ongoing as well from the EPA pilot that was last year. EPA rollout is on a little bit of a hold at the moment, but I do anticipate that will happen within this year, if not within the academic year, within the calendar year. And I think that will give us a lot more to work with in terms of understanding assessment of competency in trainees. Anything else, Bridget, that we're working on that's exciting? I don't know.
Not that I can think of, but just a few closing comments related to this overall sort of area of research and topic. I think it's been said, but just to clarify that Simple provides this platform to assess autonomy and competence. About a dozen institutions paid to participate in this non-for-profit organization so that they could gather that data. So we have really limited data for these studies that we've been doing. I mean, it's better than most educational multi-institutional studies that we can do these days, but it's still limited. And probably a select type of institution that's going to invest in this type of technology and gather these assessments. So entrustable professional activities have some similarities and some differences to specific cases. And we're rating on an entrustment scale, which is a little bit of a different concept than autonomy and performance. But by and large, we gather the assessments the same way with this mobile app in real time. And if all programs are participating in the same standardized assessment tool, I'm just excited at the amount of information we could potentially glean from that. If you think about some of these comparisons we've been discussing, that we could do that really with complete national data is pretty exciting. And agree with Dr. Weaver, the pause at the American Board of Surgery level has been related to making decisions about the app platform. And they're anticipating that we should be able to roll out vascular EPAs at the beginning of this coming academic year.
It's really exciting. I'm sorry, go ahead, Dr. Humphrey. I was just going to commend our authors. As Dr. Forbes was saying, we are very, very lucky to have these educational gurus who are figuring out how to adequately assess our trainees and help them be even better than us.
Well, thank you. Thank you, Dr. Kemp, for taking care of the education articles, because I think they can sometimes be a little bit tricky to kind of go through. And I want to thank everybody for being here, our authors tonight. It's so important to have them join us so that they can help give us that insight and more information than what is just in the paper. Join us again in March 12th. For the JVS Online Journal Club. Again, you can go ahead and register at vascular.org under the JVS Journal Club section, and we will see you in March. Have a lovely evening.